Good evening, ladies and gentlemen. My name is Ahmed Ahmed. I'm a surgeon. I'm also a council member, Royal College of Surgeons, and it gives me great pleasure to welcome you all tonight on our discussion topic on how to do a clinical audit. Clinical audits are super important, not just only when you're practicing doctors, but even at your stage. If you can do an audit, show that you've done it, it will really look good on your CVs when you apply for jobs, especially if you can get them published. And certainly performing clinical audits is something that all doctors must do throughout their professional careers. I'm joined today by Dr. Agat Sharma and Mr. Patrick Jewell, who will introduce themselves. And without further ado, I will pass the mic on to them so they can begin their presentation. Thank you very much, gentlemen.
Thank you. Right, hello everyone. My name is Agat. I'm one of the core trainees currently working in Hastings, and I'm also currently a Future Surgeons Forum member with the RCS. And we've got Patrick with us as well.
Hi there, I'm Patrick. I'm an educational fellow in general surgery, and very happy to be here today to talk about clinical audits. Next slide.
Okay, so that's what we're going to be talking about. So it'll be a run through some of the practical aspects of doing an audit, and then it'll be followed up by some question and answers. So just feel free to ask any questions you have at the end. Next slide.
So just a bit of an overview of what we'll cover today in the talk. So we'll give you a bit of the basics behind quality improvement and audit, some of the terminology, and then move on to why you should do an audit, not only for the patients, the service that you're in, but also for yourself. Then we'll cover the whole audit cycle and loop. We'll then go through a bit more about the practicalities of being able to perform an audit in hospital, because there can be some perceived difficulties with doing this. And then what to do after you've done your audit to get the most out of it for the service and for yourself. And then we'll end with some useful resources that you can take a look at. Okay, next slide.
Okay, so just going through the basics of what a quality improvement is and what clinical audits are. Basically, quality improvement is a process that aims to improve healthcare delivery. And when thinking about quality improvement, you can think of healthcare delivery under various facets. So how effective it is, whether or not it's safe, how efficient it is, whether or not it's delivered in a timely manner, etc. And basically, quality improvement measures performance within each of these domains. It analyzes this, and then it seeks to improve the performance. And a clinical audit is just one of these tools that we have at our disposal that helps us carry out this process of quality improvement. And when you do a clinical audit, what you're doing is you're basically measuring the current practice against clearly defined guidelines, and then you are recommending changes in order to help improve healthcare by improving the compliance with those guidelines. Next slide.
So there's lots of different reasons that you might want to do a clinical audit. For the patients and the service itself, it's a very simple and effective tool for enacting change in the service, and you can be helping patients have better care, preventing complications, and enabling the service to progress. As I said, it's easy to implement. There's audits been around for a while, and most departments know how it works and have a straightforward way of going through an audit and starting to enact change. Also, on a more personal level, audits involve gaining knowledge about guidelines, whether that's NICE guidelines or Royal College guidelines, and it helps to build your knowledge for going further into that field. It also allows you to be part of the department and make a change in that department as well. Sometimes as medical students, you feel you can't be involved or you can't make a change, but you can, and these audits can have big effects in departments where you work. Also, audits are required at every level that you progress. So as a foundation doctor in F1 and F2, you have to show evidence that you've participated in audits, and you have to show certificates for this. And then moving on beyond, every 5 years, if you're revalidating, you have to show evidence that you've done a full cycle audit. And if you're applying for specialties, whether that's core training, whether that's higher specialty training, you get extra points on your applications if you've done audits, and even more if they're full cycle audits, which we'll come on to a bit later. Next slide.
Okay, so talking about the audit loop, we start at the very top. So the first thing you do is to define the guidelines against which you wish to measure the current practice. Then you move on to actually collecting the data itself. You want to know what practice currently looks like and how we're doing. Then you will compare this against the guidelines that have been published, and then depending on what you find, then you'll be in a position to say if any changes are needed, and then to actually go on and implement these changes. Once you recommend the changes, and once these have been implemented, then there's the important bit of going back, seeing what difference the changes that you've recommended have made, if any, and that will be covered in the re-audit, and that basically closes the loop and completes the audit cycle. Okay, next slide.
So how do you get started with clinical audit? So it might seem a bit difficult to do it at first, but actually there's quite a few different avenues for you to go down. One of the best ones is to approach surgeons in your department, whether that's registrars or consultants, because often these members of the team have ideas themselves and maybe don't have enough time to fully enact them, or they're halfway through an audit and need some help. So often there's people who are around who are already doing audits who might be able to help. And this doesn't have to be in surgery. I know a lot of you will be placed in medical jobs, and in foundation you'll be in GP, A&E, all these different places. So you can do audits in all these different places, and that doesn't matter for your applications in the future. It doesn't have to be surgical. So take every opportunity you can to talk to seniors and see if there's any audits that are going on. Sometimes, well, most departments actually have a designated audit or governance lead. This person is tasked with making sure that audits happen, making sure that national audits are adhered to, and that significant events are investigated. And part of that might be an audit to see whether we're adhering to a guideline. Departments themselves often have to do audits. So every year they might have mandatory audits on hand washing, venous thromboembolism prescribing, generic prescribing, and documentation, which are all ones that have been done before that you can do again, and maybe think of a different way of enacting change and improving the service. National audits like the STAR Surge, which is a collaborative that do national audits, ask for medical students and foundation trainees to help with them, so you can always look out for them. And things like the national laparotomy audit or falls and fragilities. So there's lots of different national audits that you can get involved on. Another way of doing it is to have a look at the service yourself. Maybe you're on the ward and you notice perhaps that documentation isn't so good on the ward, or prescribing is not up to scratch, things are being missed. You might think, how can I improve that? So what you would do is you'd develop an audit to measure the service against the guidelines and see what you can do to change it. And the other way is just to talk to other junior doctors on the ward. So the foundation trainees might be doing their own audits or might want some help. So have a chat to people in the team and see if there's anything that you can help with. Next slide.
Okay, so when it comes to actually designing your audit, the first thing you want to do is think about a topic. And usually this will be something quite broad, and this might be something that you are personally interested in, or it might be something that you've identified in your own practice as something that needs improvement. And it can be anything really that you've seen in practice that you think needs to be improved. So to take an example, you can say that my topic of audit is VTE prophylaxis. After you've thought of a topic, the next step will be to develop an aim for your audit. So what are you aiming to do with your audit? And again, this will be quite broad as well. So in our example, it might be, your aim might be to increase compliance with VTE prophylaxis guidelines, for example. After you've defined your aims, the next step you want to do is to come up with an audit criteria and audit standards. So when you're thinking about audit criteria, this is the specific bit. So this is the specific aspect of practice that you are measuring against. So in our example, you might say that patients admitted to the surgical assessment unit must have appropriate VTE prophylaxis prescribed. To get ideas for your audit criteria, you can look at guidelines such as NICE guidelines, you can look at National Society guidelines, you can look at CCG guidelines, etc. After you've defined your audit criteria, then you can move on to defining a standard for your audit. So usually for this step, you'll come up with a target. So in our example, you might say that 100% of the patients who are admitted to the surgical assessment unit need to have their VTE prophylaxis prescribed appropriately. After you define your guidelines, you then go on to start collecting your data. Most of the time, the data you collect will be retrospective, but there's always an option to sort of set up your audit that you collect your data prospectively as well. And when you're thinking about data collection, just try and keep things simple. So make sure that the data points that you collect are objective measures, and make sure that you don't go and collect all the information about a patient that there is to know, and just make sure that you streamline it and only collect data that you need at the end. Because oftentimes it's quite tempting to, when you're at the data collection phase, to just collect everything there is, and then when it comes to analyzing and having a look at the data, a lot of it you won't end up using. And finally, another thing to think about is also the time period over which you'll collect the data. So if you're doing data collection retrospectively, then think about whether you want to go back 1 month, 3 months, 6 months to collect data. And usually this will be guided by an idea of what sort of numbers you want. And there's no sort of hard and fast about the actual number here. Next slide.
So once you've had a thought about how to design your audit, a really important step is registering your audit. Now, every audit you do needs to have a clinical lead, and that will be, in most trusts, a consultant. So you always need to discuss an idea for an audit with a consultant eventually and get their sign off. And then you go through a formal registration process with the trust. So every trust has a audit department that are, in my experience, always very helpful, and they have pro formas that you can use, which can help in designing your audit as well. So it's well worth going on the intranet or giving them a ring and asking to see if they have any resources available. And this formal registration needs to be filled out. You then show it to the consultant or the lead on that audit to check that everything's been filled out okay, and then you'd send it to the audit department for looking through. And then normally there's governance meetings every month which will look through all the audit proposals and say whether that's okay. And if your audit's been designed well and it's a good idea, most of the time it will be signed off. If not, they'll give you reasons why, and you can adjust your registration appropriately. If you have any questions with this, again, the audit departments are always very helpful, so you can give them a call and ask any questions that you have. Next slide.
Okay, so when thinking about the actual data collection itself, it's very important to think about the logistics. So first of all, as we mentioned before, decide what data points you need. And again, keep it simple and don't collect what you won't need. And this needs a bit of forward planning. After that, you want to think carefully about where you're going to look for this data. So are you going to look at the patient notes? Are you going to look at the clerking performer? Will you be looking at the drug charts? Will you be looking at the theatre log, for example? And you want to have a forward plan as to where exactly you're going to find the data that you need. Some trusts keep electronic records, but most of the trusts, I think, still use paper records for a lot of to store a lot of data. It's easier with trusts that use electronic records to go and find the data that you need, and especially if you're collecting data retrospectively. With paper notes, they might not always be available on the ward. So again, that's another thing that you need to think about. As to who you need to contact to try and get access of old patient records. But at all times, it's very important to keep sort of consider patient confidentiality. So make sure that any data you collect is saved securely. So password protect your documents and then store it in a trust computer where nobody else is going to have access to them. And again, thinking about where you're going to actually store the data, something simple like an Excel spreadsheet works just fine, and it'll help you quite a bit at the end when it comes time to go through the data and analyze it. Next slide.
So once you've got all your data, you need to have a think about how you're going to analyze it, and it doesn't involve any special statistics. It's often just expressed as a percentage. For example, you've looked through records and you've noted that 80% of the patients that you've seen who were on anticoagulants and had a head injury had a CT head. You don't need anything more complex than that, really. You then compare this with the guidelines and see how far away from the market is and how far away it is from the standard that you developed at the start. And then you need to have a think about why the service might not be at that level and what kind of things you can think about to try and get the service up to that level. A key part of it is presenting your findings at a departmental meeting. So again, every department has either once a month or once every couple of months audit meeting or a governance meeting where you talk through mortalities and morbidities, as well as presenting audits. And this is a great way to disperse information and get ideas about how things can change, or ideas how maybe the audit doesn't represent the service. As well as that, all as part of the audit registration, you normally have to promise that you will provide a formal audit report to the audit department. This is so that they can log that the audit's been done, but also so that they can follow up and see if a re-audit can be done in the future and if any change has occurred. Next slide.
Sorry. So depending on the findings of your audit, you'll then be in a position to recommend any changes to practice. If the current performance did not meet the target that you'd set earlier, then you need to start thinking about why this might be. Usually any changes to practice will need to be discussed with the department first, but at no matter what stage of training you are in, it's always a good idea to be proactive and then to recommend some changes that you think will help improve things. And when recommending changes, it's important to be quite specific and then try and propose concrete steps as to what you think will be good for the improvement of the service going forward. Sometimes when you do audits, you might find that actually the performance is meeting the targets that you had set out. And even if that's the case, it's important that you let the department know, because it's good to get some positive feedback, but it also means that we can continue with the current practice that we've got, if it is the case that we're meeting our current targets. Next slide.
So a key part of the audit process is implementing a change. A single cycle audit, just seeing if the service adheres to guidelines, is great, but then if you don't do anything with it, you haven't changed the service at all and there's no benefit to the patients or the clinicians. So how do you implement that change? This is quite a complex area, but there's a few things that you can try and do to do it. So breaking it down, it's basically divided into, can you change a system and can you change people, individuals? So changing a system can seem difficult, but things like checklists can help. So we have the WHO checklist for theatre to make sure that we've got the right patient and we're operating on the right limb. And the same thing can be done with prescribing, or when someone's being clerked in, you can have a checklist. Are all these things being done for someone who comes in with small bowel obstruction? Or are all these people, is everyone with sepsis having these things done? So that's something that you can consider and present to an audit department. So the other side of it is education and changing people's practice. So this can involve a departmental meeting. So you're telling all of the clinicians there what the most up-to-date guidelines are and how the service is or isn't meeting that. So that can be a good way of education. You can send out emails, you can have face-to-face chats on the ward with foundation doctors just to say that, oh, we had an audit that showed this. Did you know that you can prescribe in this way, which adheres closer to guidelines? If there's electronic systems, this can make things really easy. So you can set up automatic prompts. So say you're on a prescribing, electronic prescribing, if someone's less than 50 kilos and they're being prescribed a gram of paracetamol 4 times a day, that's too much, and the electronic prescribing system can flag it. So you could set that up at a local GP's or even in the whole hospital if you talk to people and think that that's a way that you can change practice. Have a think about the interested parties. It's all well and good educating people, but who is the one that, or who are the people that are going to be prescribing? There's no use focusing solely on consultants. Maybe if it's a prescribing problem, the people who generally prescribe are the junior doctors. So it'd be better, you have to involve the consultants, but the teaching should primarily be involving the junior doctors to tell them about what the guidelines are and what needs to change. Next slide.
Okay, so how do you follow through on your audit? So once you've completed the first audit loop and you've recommended the changes, now you should allow some time for the implementation of the changes that you've recommended. But after a certain amount of time, you'd want to go back and see if the changes that you've recommended, if the changes that you've made has made any difference to practice. And that's when the re-audit comes in, and it's a really important step of the process, and it's important that you always try and close the audit loop, because you want, as Patrick mentioned earlier, it's well and good to see what current practice is like, but the main aim of this is to try and improve healthcare delivery. Now, sometimes this might not be possible because you might have rotated onto a different trust, you might even have rotated onto a different geographical location. And in these instances, it's quite important to collaborate with other team members. So you might wish to speak with doctors who you know are going to be there in that department for a longer duration of time than you are. Or you might even speak with some of your other medical student colleagues who you know are rotating into that department and into that trust to try and pick up things where you left it, so that the two of you collaborate and then try and complete the audit loop together. An alternative to this is checking up with colleagues in the department to see what the progress has been like since you left, but this is less formal and it won't lead to the audit loop being closed, so it's not as ideal as actually completing the audit loop itself. Next slide.
So once you've done your audit, maybe the whole cycle, where do you go? How can you take it further? So not only can you present it at departmental meetings, you can present it at regional meetings, national conferences, and international meetings. Often all of these have poster presentations, which are ideal for you to get across the audit that you've done and the change that you've implemented, and then you may be able to get prizes for this and go further. One thing you can also do is you can write up your audit and publish it. So a basic audit on VTE or documentation might not be able to be published, but if you've done a more complex audit, or you've shown that you've made a massive change or a novel way of implementing change that has had a concrete benefit on patients, then you can definitely write the audits up. And because you might have a brilliant idea that other trusts and other departments can replicate and put into practice. So have a chat to the leads of the audit and ask, do you think this audit's suitable to write up? If so, can I try writing it up, and then showing it to you, and then maybe publishing it? So you can definitely take that opportunity. Okay, and don't forget, get a certificate from either the lead on the audit, the consultant lead, or from the audit department, because it can be a really big hassle 2 or 3 years down the line when you're applying for specialty training. You realize you did a full cycle audit, but you can't find the certificate. It can be very hard to go back to the audit department and get a certificate. So make sure you get one and you save it in a place that you know where it will be, so you can use it for the future. Next slide.
So just to point you towards some useful resources that you can have a look at to sort of supplement this webinar. There's a couple of organizations, the Healthcare Quality Improvement Partnership or the National Quality Improvement and Clinical Audit Network. So they have quite useful information on their websites, and also some good examples as to the kind of audits that you yourself can do. So I definitely recommend having a look at these. But another very useful resource that you can use is, as we mentioned before, your local audit department. So if you approach them, they can guide you through all the steps of the process, from planning and designing your audit through to sort of actually doing it and then presenting your findings. So definitely recommend speaking with them as well as another resource. Next slide.
So that comes to the end of our presentation. Just a little recap about what we've talked. So we had a brief introduction about the quality improvement and how clinical audit fits into that and could be a brilliant tool for change in a service. Covered some of the reasons, both personal and from a patient point of view, why audit is important. Then the audit loop, where you define the guidelines, you measure the current practice and compare against standards. You then recommend and implement changes, and then you go back and re-audit. And again, that re-auditing is such an important point to make for making change. And then how to get involved in each step. So designing it, collecting the data, analyzing it, presenting your findings, and taking it on further. Thank you.
Well, that's great. Thank you, Patrick. Thank you, Agat, for a really fantastic overview of how to conduct a clinical audit. We're now open for questions. So can I just remind the audience, please, if you have any questions, enter them in the questions tab of the system. We have some questions which I'm going to put to you both. First of all, let's start with this one. Agat, what are the best topics for auditing, particularly as a medical student?
Okay, so the answer to that is pretty much anything, to be honest. So depending on the rotation you're in, as Patrick mentioned earlier, it doesn't have to be surgically orientated. So if you're in a GP setting, for example, you can look at an example of an audit I did was looking at annual reviews for epilepsy patients, for example, and whether or not the GP surgery was meeting the standards for that. Other examples, common ones that you can look at are things like VT prophylaxis. That's a common one. CT scanning for head injury patients, whether or not we're meeting guidelines for those. That's another common one as well. Or even something very simple, such as when I was in a placement in ICU, for example, I did an audit on how frequently the treatment escalation plans or the DNA CPR forms were being filled out. So any aspect of healthcare, you can have a quick look at the guidelines and take it from there.
Yeah, I mean, I agree with that. I think something that you both said, which I think is really key here, is I think as students, you won't necessarily know what to audit, but the best thing to do, as you suggested, is to go to the consultant or the registrar and just say that you're really keen to help and do an audit, and is anything on the firm or the team that the registrar, the consultant, would like to be looked at. And I think that's a really good strategy. Patrick, do you want to add anything to that question?
Yeah, no, I completely agree. There's lots, people think that you have to do a complex thing as well, and it's not about that. You can do simple interventions to make change. So prescribing and things like that are great things to jump on. And GP practices, actually, when you're on a rotation, are perfect for that because it's small. You can make a big change quickly because there's a few GPs there and nurses, and they have electronic systems, so you can put reminders in, and then you can come back if you're coming back to that GP practice in a few months if you're on another rotation there. So it's perfect to do that re-audit. And I did a couple of full cycle audits at the GP practice when I was a medical student, so it's perfect opportunity.
Great. So the next question we have is, how long should the topic under audit be monitored for?
So it all depends on what you're doing. So if you're doing something which is a rarer condition, you're not going to have it come in that often. So if you're doing something in a district general hospital, maybe about rib fractures, and you only have a couple of patients coming in every week with rib fractures, and you want to assess if their pain relief is prescribed according to guidelines, you may have to be collecting data over quite a few months to get a valid sample. Whereas if you're doing a documentation audit, you might be able to get that done in look at records over just a week or 2 weeks. So you want to have enough, maybe around 50, so that you can make an inference, and that it's not just by chance that you've missed things, but you don't want to do so many so that you're spending far too long collecting data.
Great. Aga, you want to add anything to that?
No, so yeah, it as Patrick said, it's mainly about getting the right number of data points, and it depends on exactly what you're auditing. But sometimes you may have to go on for quite a few months, whereas if it's a common thing, you can easily get about 50 data points to go on and analyze your findings.
Okay. The next question is, how important are audits for the foundation program application, FY2 standalone included?
So for the foundation applications, from what I remember, audits themselves don't give you any points per se. If you are applying for the academic foundation programs, then there's always the opportunity to talk about it during your interviews, and I think there is a bit of your application for the academic foundation program. But for the normal foundation program, it won't give you any points. But again, it's something that you need to do as a foundation doctor. And when it comes to applying for something like core training a couple of years down the line, you can always talk about the audits that you've done as a medical student. And it will give you points to have done audits when it comes to the application for core training. With regards to FY2 standalone training, I'm not entirely sure what the process is, so I might have to look into that.
Great, thank you. How can we ensure that we do not blame a certain department or group of people for the results we obtain from the audit?
So it is very important that we aren't blaming individuals. The the good thing about an audit is it's objective, so you're comparing to guidelines, and as long as you're rigorous in how you collect data and it's an objective point, so you can say that this patient did not have a CT head at this time, and you can present that. You present it as a service whole. You're not blaming any one individual or anything like that, so you shouldn't come across as blaming. And then when you're looking at the things that come out of it, maybe the reasons you're not adhering so much to the guidelines, you can, again, it's not about a blame. You can just say, perhaps we're not filling in these parts of a checklist at the time. Maybe we're not filling out the prescriptions completely. So you have to be careful not to apportion blame, but the audit process is objective, and so it shouldn't come across as if you're labeling anyone's as being at fault.
Yeah, the next question is actually a similar theme, which is, from my understanding, the basis of an audit is to see whether guidelines are being followed, and if the audit proves that this isn't the case, how do we go about not assigning blame, or is blame inevitable in an audit? Agathe, do you have any comments?
So yeah, basically, as we mentioned just now, it's an audit usually looks at the processes rather than any sort of individual or a group of people. So the main aim is at looking at the practice and the systems that are in place in a department or a ward in general, rather than looking at any group of individuals or any one individual. So blame is, whenever I've done any audits, the departments that I've worked in, they've all been very open to any suggestions that we've had to make, and it's generally a case of us improving as a department rather than focusing on any one individual and assigning blame. So that shouldn't really be an issue.
Exactly. It's the whole aim is for improvement of the service we provide. It's not about blaming. Okay, next question is, can we write a publication or article based on an audit we've conducted in practice?
Definitely. So often, being a trainee, you have to try and maximize everything you can get out of everything that you do. And as I said before, if it's something small, it might not be necessarily applicable for writing up. But if it's a big part of the service, you've made a big change, so you've done the full cycle audit, you've re-audited it, you've made a big change from going from maybe 20% of people aren't having something done, and then you're reaching 90, 100%. That's the kind of thing that journals want to hear, and more about the process, about how you implemented that change. So not only are there sort of journals like the BMJ and BGS, but there's also health improvement journals, quality improvement journals, where these are exactly what they want to. So I would recommend, if you've got an audit, looking for those kind of journals that are labeled quality improvement, health improvement. Those are the kind of journals that want to have publications related to making change.
Great. How many complete cycle audits are enough for portfolio building up?
So that depends. So different specialties will have different requirements. So for, I think, general surgery, they ask for anywhere to 5 to 7 closed loop audits over the course of your medical training. But there's no set number that you have to do to reach anywhere, but the more you do, the more you can talk about, and the more closed loop audits that you do, the more points you get when it comes to higher application training. But for specific numbers, you'd have to look at the individual sort of specialty application checklists.
I'd just like to second that as well. It's the closed loop audit that is really important. For example, if you're applying for a general surgery registrar position, you get the same amount of points for a three loop cycle as you do for doing 7 or 8 single loops. So it's really important to close that loop, because you're making a change and you need less of them for your future applications.
Okay, next question is sort of similar to one of the ones that we answered before, which is which conference can I present my audit at? So I think you mentioned some journals, but what about conferences, Patrick?
Yeah, so if we're thinking about surgery specifically, so the Association of Surgeons in Training, or ACIT, is perfect for these kind of things. You can present your audits. That's a great one to present surgical audits at. And there's other trainee groups in medicine and GP where you can present them. There's also specific health quality improvement conferences as well. And things are transitioning more to online now because of COVID, but they're still accepting posters, and they're still accepting virtual posters where you can present your work. Have a look for regional meetings as well, which might be easier to get into. But yeah, ACIT is definitely a top one to go for.
Yeah, and the other place, of course, is at your most hospitals will have in their surgery units their sort of monthly M&M meetings, and often, certainly in our trust, the students who do the audit, they often present internally at these meetings.
And just to add quickly to that, depending on the topic of your audit, you can also look at specialty specific conferences where you might be able to not necessarily do a big presentation, but maybe show a poster that you've made on your audit. So specialty specific conferences are also another possibility.
And often conferences have specific areas for audit, so you have to submit your posters under whether it's maybe trauma or orthopedic or colorectal surgery. They'll also have one which is specifically on audits, which is perfect for your posters.
So we have another question here. Can you guide about some novel ideas for audit from general surgery? So I think we've kind of answered that already, but I would again say, speak to your the service you're working in, or the team you're in at the moment, the consultant or the GP, and just actually ask them, what would you like for me to audit? I mean, because as you mentioned before, a lot of the clinicians are super busy, so we don't get actually time to do the audit ourselves. So it's a really nice thing for a young keen student to offer to do the audit for us. So I would definitely ask somebody.
Yeah, and have a look at guidelines as well. So the Royal College has guidelines on good practice. So I've done an operative note audit based on Royal College guidelines, where I've done a full cycle audit and produced education and checklist for good operative notes. You can also look at specific society guidelines as well and pick one thing out of it. So sort of you could look at NASBO, which is the National Audit of Small Bowel Obstruction, their recommendations for scanning for small bowel obstruction early and getting early nutritional assessments. That's the kind of thing that's very easy to assess. So have a look at society guidelines, and that can give you some ideas about things that you could investigate.
I mean, another sort of low-hanging fruit would be, in current times with COVID around, I mean, it's changed surgical practice for all of us. So an easy audit to do would be something like, I don't know, FFP3 masks, or the sort of precautions we're taking now, and their guidelines about that, and whether the surgical teams in your hospitals are following those guidelines or not. That's pretty easy to do, actually. So that's one more idea for you. All right, next question is, what if there were no standards we are working against? For example, if we want to measure the utilization of our theaters, our audit department wouldn't agree to register it as an audit.
That's an interesting one. So usually definitions for clinical audits, they can sometimes be quite rigid. So usually you'd be comparing against guidelines that have already been set. If you're not comparing against guidelines, then that might fall under the bracket of research rather than audit. And it's certainly something you can do. but the processes that you'd have to follow would be slightly different for that. I don't know if Patrick might have something.
Yeah, so as Agat said, if you haven't got any standards and you're creating standards, that's research, and it's a lot different to audit, and you need to get ethical approval, and it is more difficult. And you're basically, the idea of research is you're creating new standards. If you're looking at the service itself, another aspect of quality improvement is service evaluation. So you're just looking, are we achieving these theatre times? Are we achieving this flow through? And audit departments also register quality improvement projects that aren't specific audits. So if you have an idea about how to reduce cost, if you have an idea to how to improve sustainability that doesn't necessarily have a guideline, there is a process that you can go through to try and do a quality improvement project, and your your audit department, sorry, will be able to help you with that. And so things like that, without guidelines, you can do projects based on them, but they're not specifically called audits. And specialty applications are adjusting that now and saying you don't just have to have audits, you can have quality improvement projects as well. So have a chat to your local audit department about that.
Yeah, I agree entirely with your answer. There's a lot of stuff that you can do under the umbrella of quality improvement or service evaluation, and that can also be very useful. Great. Next question is, how much time on average does conducting an audit take?
So
Yeah,
it depends. Sorry, it depends again. So you can actually do one very quickly. So if you have an idea and you register it, you can collect the data, say from the last 2 weeks, and that might only take you an hour, and then you can think of ways to implement. So the minimum amount of time is probably less than a month to do a full cycle audit, but that's in best practice. Often it would take you a whole rotation. So if you're a foundation, you could do one foundation doctor, you could do one very early on in your rotation in the first month, and then re-audit it in the 4th month, and that will give you enough time. But you can't, there's no one set duration for the audit.
And the only thing to add to that is the best thing to do to try and minimize the effort and the time it takes is to collaborate with other people. So if you've got a friend who's also in the same department, same trust, you can ask them to help out with data collection, and that way you don't have to keep going to the trust to do all the work yourself. So just share out the work amongst people to try and make it easy for everyone.
Just make sure they're listed as well as an audit sort of helper when you're registering it, because sometimes audit departments won't give certificates unless they're registered initially. So just be careful of that.
Great. Is it appropriate to use guidelines from non-UK international guidelines if the UK guidelines in that particular area are old?
The answer is yes. It depends on which international source you look at. So sometimes if it's an international society for a specialty, for example, then it might be that they've published guidelines around their specialty. You can certainly use that, but just be careful that it is something that's applicable to the system here as well.
How can you do audits in areas where there might not be established national guidelines? Can we do audits based on guidelines established by the departmental head or someone else?
Yeah, so you can use departmental guidelines as well. So if you've got a trust document maybe that says that all patients who present with this should have these blood tests done or something like that, that's a guideline that you can compare against. You're auditing the service against the trust guidelines, so you can use trust guidelines for that as well.
Are there any audits that can be done remotely?
Difficult. So you can do, because you have to be in the hospital to use the hospital. Even if it's a electronic thing, you won't be able to have things like VPNs as a medical student to be able to access patient information from home. So you will have to be in the hospital, and if you're taking any information out of the hospital to analyze it, that has to be anonymized as well. You can't take Excel documents with patients' names, or, well, you wouldn't take patient names anyway, but with patient numbers and things like that. So you can do sort of some of the designing the audit and working on the presentation remotely, but I think most of the time the data collection will have to be done from when you're in hospital.
All right, next question is, I'm applying for CST, but my audit has not showed a change as such. Just to continue with current practice guidelines which were met, does it look better for an audit to show that it's implemented a significant change?
Not necessarily. So in terms of the core surgical training application itself, you, as long as you've completed the audit loop, it doesn't matter what your audit was able to show. However, as we talked about earlier, if you're wanting to take that further, and if, for example, if you wanted to get that published, then it might be a bit more difficult for you to have your audit published if the recommendation was to simply continue the current practice. But in terms of getting points for the audit itself, it doesn't make a difference whether or not you were able to show any change in practice.
Even if your audit hasn't shown a difference, you can suggest ways that it might be easier to adhere to the guidelines or do even better. So you might be getting 90% of reaching the guideline 90% of the time, which shows that your service is doing well, but you can also think about how you would get it higher. So even if you notice that if you audit it and the service is doing well, you can think about ways of improving further as well.
Next question is, when you say you can present a poster, what should the poster show? A flow sheet, a closed loop diagram, or pie charts?
It'll depend.
Anything. Sorry, you're gone.
Yeah, it depends how you structure. So most posters have sort of a background, introduction section, then a methods of how you did it, your results, what change you did, and then what you brought, your re-audit results, and then a conclusion about how practice has changed and things like that. So it depends, and it'll be a combination of diagrams and things like that. So both flowcharts and pie charts are applicable, but it all depends on how you're structuring your poster.
Great. I think this is the last question now. Say you want to do an audit based on mask usage in surgery in times of COVID. Do you have to enter the operating theater every time and check on the surgeons about what they are wearing, or just hand them a questionnaire when they exit? What's more acceptable?
So that's an interesting one, actually. I don't think it would be practical to be in theatre all the time to see what sort of compliance there is. But you could either take a sample, sort of choose times when you're in theatre for a particular amount of time, and then use that as a sample to extrapolate what practice might generally be like, or alternatively asking clinicians to fill in questionnaires might be a suitable alternative as well. But I don't think there's a hard and fast way of sort of doing that, really.
Okay. Is there a formal way of writing down an audit so it's well presented? Any suggestions?
I think that the best way is to follow the audit cycle if you're presenting on a poster. So we've illustrated how you define your guidelines and your standards, and then you compare your service to those, that you get your results, and then you think about how you make change, and then you make that change, and then you reassess. That probably the best way of presenting it is going through that cycle again. That's what I would recommend.
Yeah, I mean, the other thing you could do is just look online. If you go to a BMJ or a journal and just type in audit and just see the successful papers that have been published as audits, you could just see how they've been written up, and you could just sort of emulate that style. I think that was probably the last question, which is great because we're just on time as well. All it remains for me to say is, Patrick Agat, thank you very much. It was a really nice lecture. I learned a lot, and it's invigorated me to begin some audits tomorrow when I go back to work. And also to our audience, thank you very much for the lovely and informative questions, and thank you very much for listening to us. So at this stage, I'm going to sign off. Thanks to all. Bye-bye.
Thank you.
Thank you.
Bye.